Good afternoon, Chairperson, my dear friends. It's a pleasure to be at India Live again. I just wanted to present sometimes we are faced with the harrowing experience of getting to an anomalous coronary artery, especially in the patient scenario when the patient presenting is a little at high risk. In this gentleman who actually presented with the acute MI in a little shock situation in another hospital, underwent a PAMI to LAD. I would say it was a difficult situation, came out and was also having some right coronary lesions which are critical. But as the operator thought so, it was very difficult to get him out of the LAD situation. So he was pretty reasonably okay with little heart failure symptoms and presented us with the angina increasing last 2 weeks before he presented to us. And his EF was less, his ejection fraction less, and creatinine also is borderline of 1.7 to 1.9 earlier. So he had an anomalous right coronary artery, which was a challenge, which we are thinking. I mean, one of the first slide was, I'll show you later, was how to tackle with this very anomalous right coronary artery, which was arising from right above the sinus of the left side and high aortic position. If I show you this, in fact, the right coronary is not seen at all there. I will show you in the later picture. No employees could sit there, as, or even the, we thought sometimes the AL1 is the best guy to do that, but repeatedly the AL1 would go to the stented left main and the LAD artery. So we tried even getting a multipurpose there. It was not possible. Then we even tried AR1. That couldn't sit there. So you're wondering what should be the next step. When we are faced with such situation wherein extreme high origin, which you can now see barely there, it is almost from the nearby left sinus, and we thought, let us try with an XB, which could be of little help, some help. But as you could see there, the lesions are one of the proximal mid and one of the distal right there, which is barely seen. Even with the a support wire of one a BMW, another wire, cyan blue, were not able to, the moment we put the wire, the guide would back out. So then you're wondering what would do the next step, what would we could do better, or we thought, in fact, I tried to take a balloon support, or even then the wires backing out. Then I realized that if you take a little bit stiffer wire, in sense like even a BMW off is not so stiff, but I thought that let us try a polymeric wire, which could be more useful, because just to cross through, because even in the previous slide, we are feeling that we were a little subintimal. That wasn't worry, because the patient was already started a little bit coughing, and the blood pressure was 90/60, because this guy had already heart failure and being in a CRF situation. So we quickly would luckily get through a Hildre FC, which is a coated wire which can go sometimes be very helpful, even though support is less. If you could see there, the distal lesion is pretty critical, and both the lesions are important for him. By the time, obviously, after this, we need to balloon the lesions. We barely could get a 1.25 balloon across the distal, because we tried 2.0, could not go through the distal lesion, and even then the guide was very much outside, and most of the times not getting engaged. So what is best is to get the best balloon possible and go and dilate the distal vessel, and also make rooms from the proximally with another larger balloon, a 2.0 balloon. With this, we thought we were getting through, but the patient was getting to a little bit heart failure, blood pressure dropping down. We had to start him on noradrenaline, and also we had to start him on furosemide. He was coughing a bit. We thought What the best ways to do is to at least bail out and stent him because he's getting to LV. I thought I'll have to intubate him. And one of the very good trackable stents, we had a very thin strut, is that this is a 2.75 26 R0. This is a very thin strut, and I believe it would really go in many places with a very little support, and it would easily track there. And I thought I'll finish off with him first. And when the proximal being stented there, I thought, because even the the 2O balloon was not going down, so I said, let me optimize him and dilate the proximal vessel with the 3O balloon. With having that done, then with the furosemide, with the little bit of Nordrin, his hemodynamics started improving. I thought we'll have to keep you calm and work. When the blood pressure came up and his oxygen saturation was dropped to 90, came up to 97, 98%, then the things were better. The wire was not going to PDA there down, but with great difficulty could get across the wire. And again, we had to pre-dilate the lower vessel, the lower lesion with a 1.25 again. The patient was still coughing, and we were trying to stabilize him. And then luckily we could dilate the vessel quickly, and then we pre-dilate with another 2O balloon, and then quickly through a stent to stent, but ideally would have done the distally first. But with this situation like this, now he was slightly stabilized with 100 by 60 BP, and quickly another 2.5, 13 or so went through the earlier stent, even though the guide was not sitting well. With this, quickly, I think we could get a very good result, and that was the final result with no much proximal dissection and a good TIMI3 flow. So what I want to tell the fellows here is that anomalous origins are a big challenge. We need to plan the strategy in advance to know, like you need to have proper guide wires and the backup catheters. More important, with different kind of guides you need to have at your disposal. You need to have alternate plans sometimes, because this guy was almost, surviving on a viable RCA when his LAD had infarcted, just treated 8 weeks back, would get into heart failure often. So when a quick bailout situation, you have to be fast and quick and think and get out of the problem as soon as possible. And of course, the wires and stents sometimes matter in such situations. We all heard that. Thank you, sir.